Hello everyone, welcome to my channel. From today onwards, I will try to cover very important topics which are important for ADAT. I will try to cover like biomedical portion also, but let's start with the biostatistics today. So I would like to include everything which is important, so you can just take notes and revise when you are going for the ADAT exam. So I have just found this one a very good thing to start with. So let's start. So let's start with the studies first. Like first thing is the analytical study. It is divided into experimental and observational. So in the experimental, it's uncontrolled trials and controlled. In the control, it's subdivided into non-randomized and randomized. Whereas in observational, it is cohort, case control, cross-sectional. So remember three C's and longitudinal. So let's move first thing to the cross-sectional studies. So these are the cross-sectional studies. So first of all, cross-sectional, uh, they always give you the study design and will ask you which study is this. So try to pick up the things like is it mentioning like some type of risk factors, and it's on the single point of time the study. So let's see the definition. So it is collected data from a group of people to assess the frequency of disease and related risk factor. And what question is what is happening in that point of time, and what measurement it's do, it's prevalence, not the incidence. Okay, remember, prevalence is by cross sectional study. Example, risk factor associated with the disease, and we are not able to see the cause of the disease. We cannot measure that. So remember, no incidence, no causality, only the prevalence. So the use of this study is useful in chronic disease to find more about disease rather than about etiology. And disadvantage, so we cannot know the causality and we cannot calculate the incidence. So this is the disadvantage. And bias, we have social desirability bias. So it's a very, very important study. So try to remember the important points so you can apply during the final ADET exam, like which study design is. So they will give you lots of risk factor are measured and give you study type, and you have to see, okay, in this point of time they are only measuring the risk factor, there is no incidence or there is no disease, dividing the individual into groups like exposed or unexposed, or in a disease or undeceased. So you can differentiate it from cohort and other one, case control. So remember all these important points. So next study is the case control study. So case means like the person with disease, control without disease. So definition is compare a group of people with disease to a group without disease, like looking for the prior exposure and risk factor. So what is asked, like question is asked in this study is what happened, means person already has deceased, then we will see, means what happened. Okay, and always remember case control A and O, so it will measure odds ratio. So a patient with the COPD with higher odds of the smoking history compared to those without COPD. And main bias, because as patient already had disease and then after like years we are like trying to evaluate the disease, so patient will not remember some of the like the person individuals we are like trying to ask, they may not remember, because and it will cause the bias called as recall bias. So it's a very important study, and when you're trying to implement this study, in the question you have to see, okay, they are giving the patient like with the COPD, means they already have the disease, and then they are measuring the odds of the smoking and like this. So and second thing we have to remember is the odds ratio. Okay, and it is a very important study. Next is the cohort study. So cohort study compare a group of like with the given exposure or risk factor to the group without such exposure. And in this study, who will develop the disease, we will try to find out. And remember, in cohort we have two O's. So two R's means it will measure the relative risk. Example for this study, who had like higher risk of COPD than the non-smoker. So in this one we are comparing, okay, and it measures relative risk, attributed risk, and incidence. And sometimes there is also recall bias in this one. Then we have comparison. So let's do the comparison of these two studies. So the first is case control, as it is retrospective from the past, whereas cohort it can be prospective as well as retrospective. Like if we are doing the cohort and we will try to collect the information from last 5 years, then it will be retrospective. Case control mostly hospital based. Reason being we have to have the person with a disease, that means case. So mostly cases are in the hospital disease people, and whereas other one is community based. Case control is quick, whereas cohort is time consuming. Easy to conduct, that is logistically difficult. Samples my size is small in case control, and in cohort it's a large sample size. Case control is less expensive, whereas cohort is more expensive. Case control is used for the rare disease, whereas cohort for the common disease. And thus cohort measure the incidence. So mostly they can frame a question like this. Also, they can give you the options, and in which they can change it. Okay, in the all options will be in like advantage of cohort, but they will say it is less expensive than case control. Then it is a wrong option because it is more expensive. Now we have the clinical trial. So in clinical trial, what design clinical trial best? So in clinical trial, in experimental study involving human design, compare benefit at least two treatment. Like one patient will receive the treatment, another one will be a placebo. So clinical trials are best. Like this question can be asked in exam. Which trial, like the which study will clinical trial will be best? So remember, it must be randomized, control, and double blinded. Both of them don't know the one person who is receiving the disease and the one who is doing the disease. So that means double blinding, and randomization should be done. Okay, it's a very important thing. Remember that one for ADAT exam. So next is the this one, faces. So the very important thing about, so phases. In the phases, we have four phases. So always remember, in the phase one, clinical trial. And as we go from phase one to four, number of people will increase. Like first thing is in phase one, there will be small number of people and they're healthy. What it will do, it will determine the drug is safe. In second trial, remember patients means people with disease. In one first number, they're healthy individuals. And the second phase will see efficacy, optimal dosing, and adverse effect of the drugs. Whereas in phase 3, we have to see large number of patients randomly assigned to new drug or best treatment of placebo. How well it work compared to the current treatment. Whereas in class phase 4, sorry, phase 4, post marketing surveillance of the patient after treatment is approved. Can it stay? How long is the side effects, adverse effect? So remember, so mostly they usually test phase 1 or 2. And remember, there is a small in healthy individual is in the phase 1, and second is the phase 2. They can ask you like this also, like which phase will measure the efficacy of the drug. Then it is phase 2. So it is very important. Then we have this one again, the testing the phases. So we have phase 1, phase 2, phase 3, the same thing, and like this. So try to remember this. Now then we have the bias. What are the three different of parts of the study where bias can have effect? Recruiting participants, performing the study, interpreting the result. When we are doing the assigning the participant, then we can do the bias. And while we are performing the study, then we can cause the bias. And after the outcome is there and we are trying to interpret the result, then there can be a bias. So what is the selection bias definition? So in the selection bias, so we are just doing the bias during selecting a group, like error in assigning subject to a study group that result in non-representative sample. Sample should be the representative of the population. Then we have Bergerson bias. In Bergerson bias, study population selected from the hospitals. So remember, in hospital they're already less healthy than the normal population. So that is Bergerson. Remember Bergerson hospitals. Then healthy worker effect. Study population is healthier than the general population. Then we have non-response bias. Participating subject differ from non-respondent in meaningful ways. How we can reduce the bias? By randomization and ensuring the choice of the right comparison and reference group. So four bias which can occur during study: recall, measurement, procedure, and observer expectancy bias. Now we have the recall bias. So remember, in recall bias we have awareness of the disorder alter recall by the subject performing retrospective study just in the case control. How we can reduce them? Decrease the time from exposure to follow up so they can remember. Then we have measurement bias. In this one, information is gathered in systematically distorted manner. So we have association between HPV and cervical cancer not observed when using non-standardized classification. So how we can reduce this? Use objective, standardized, and previously tested methods. Then we have procedure bias. In procedure bias, subject in different groups are not treated the same. Example, patient in a treatment group spend more time in highly specialized hospital unit. So we can use how we can reduce them? Blinding and use of placebo. And next one is the observer expectancy bias. This bias usually occur during the when the researcher believe in efficacy of treatment changes the outcome. So the researcher think this treatment will be successful. So he already believed that. So his if observer expect the treatment group to show signs of recovering, they're more likely to document positive outcome because they're only considering the positive thing. Then how we can reduce this? By blinding and the use of placebos. Now we have what are the two types of bias that can occur during result. When we are doing the result, then we can have confounding and lead time. So remember lead, EA and early. These words. Oh, let's see the confounding first. It's very important. Sometimes they will ask you the confounding factor also. So remember the confounding bias. When a factor is related to both exposure and outcome, but not the causal pathway. So just like smoking cause COPD, but there is one more thing we include, okay, alcohol or other like drugs. So that's our confounding factor. So other risk factor to the exposure to the outcome. Like pulmonary disease is more like in coal worker than the general population, but coal workers are more likely to smoke than the general population. So how we can reduce this bias? Multiple and repeated study, crossover studies can be done, matching patient between control and treatment group, restriction and randomization. Then the very important bias is lead time bias. As I told you, EA for lead and EA for early. So early detection is confused with the increased survival. For example, we are going to say, okay, this patients are we are seeing the period of 5 year, and but we see the like early we detected during 3 years there's more survival, and then we feel like, oh, this treatment is effective, but the early detection is confused with the increased survival. So we think the survival has increased, but in reality it has not. How we can reduce this? Measure back end survival, adjust the survival to the severity of the diagnosed disease at the diagnosis. See the severity and this. So remember, very very important this one. Let like lead or let you wanna say, and then EA for early. So this one I will start from the next slide. I want to make the short videos so it can easy for you to remember. So this one will start in the next slide, in the next video.